order. Um, It is 5:31, and I would like to, first of all, take the privilege as chair to congratulate Julie on her, well, it wasn't a win, it was, you're in a runoff, right? Right, congratulations to you, and good luck. We hope that everything works out well for you. And I'd also like to start with outlining the agenda order. We will be taking agenda item number 10 first, then item number 3, then item number 2, then item number 4, 5, and 6, and 7, and then finally item number 1, and then the adjourning item, which is item number 11. Right?
Yes.
Okay. What we're going to try this meeting is that I am going to lay out the item. I'm going to outline the amount of time that we've allotted for each of those items. When we get to the point where we are exceeding the time, individual board members can then move to limit the discussion at that point in time if they feel that that's appropriate. But I will interrupt the individual who has the floor and ask and let them know that we have concluded the time for discussion, and hopefully that individual will wrap things up in about 2-3 minutes, and we can move on to the next item. Prior to discussion and placing the motion on the floor, I'll attempt to try to explain what we're trying to accomplish. I think sometimes we go into this and don't know whether we are approving something or it's just for discussion. So I want to make it sort of plain for individuals that this is either just for discussion or it's for discussion, and if our discussion leads us to want to take a motion, then we will take a motion at that point in time. And I think that's about it. We really would like to focus our discussions on the agenda item. So I know that at times there are broader items that people realize at the time that we're discussing this, and I really think we'll get a chance to do the broader discussion as we do the budget, because the budget items and those line items create the opportunity for getting an update or addressing an overall issue with regard to a program. So with that, I would like to take up agenda item number 10, and it will be in closed session. Discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated. And I would like to announce that the committee is convening an executive session to discuss agenda item 10 under section 551.085 of the Texas Government Code, deliberation of governing board and certain providers of healthcare services. And it is 5:35. We're good. Okay, thank you. It is 5:46 and we are back into open session. And I would like to take up agenda item number 3, discuss and take appropriate action on a recommendation for a commitment to a permanent supportive housing project expected to reduce emergency department visits and hospitalization rates among the homeless in Travis County. We have allotted about 20 minutes to be able to present this and discuss this item. And I would like to turn the floor over to Mike Giesland.
Yes, thank you. Members, there's a memo in your board packet that outlines this issue, and I'm not going to read from it verbatim, but I will pull from this memo and teeing up this issue. So the decision that you have to make tonight is, or that we're asking you to make tonight, is a funding decision. And it's, the staff recommendation is for $400,000 to support a program, permanent supportive housing. And I'm going to read directly from a presentation that was provided to me. And it says, permanent supportive housing is an evidence-based housing intervention that combines non-time limited affordable housing assistance with wraparound supportive services for people experiencing homelessness, as well as other people with disabilities. And as you're contemplating, how to process this decision, what you're looking at is there are certain savings. Whenever you provide stable housing to individuals, there are savings in the criminal justice system. There are savings in the healthcare system. We fall under the healthcare system. And as there are savings, so for example, lower ER utilization. So if you have homeless individuals that are now into stable housing and they are no longer utilizing the ER as much, it stands to reason that there will be savings with that cohort of population. Now, you are spending additional funds for their primary care and their specialty care, but taking that into account, there's still estimated to be a net savings. The way this works is you take some portion of that net savings, and you allocate that towards paying for this housing if certain metrics are met. And so it is pay for success, meaning you have to cross certain thresholds, certain milestones before you pay anything. And so what you are doing is you are committing funds up front. Now, I'm advised that because of the timing of this and the way the cash flow works, that even though you would commit from fiscal year 2018 budget, in reality, the transaction may not occur until towards the end of the following fiscal year, meaning fiscal year 19. But given that this is a multi-year project, you would have the Central Health Board of Managers would need to come back with each successive budget cycle and make sure that you've allocated sufficient amounts to be able to cover that obligation. In part because of the financing of this works where they can see into the county commissioner's budget, the central health budget, the city's budget to determine, have you actually set aside the necessary amounts to be able to help fund this program? There are private investors that are also helping to support this program. And those private investors, and I'll won't get into the detail about, I'm not sure who, but they're at risk on this, meaning that if the program is not successful, then those private investment monies, not the central health monies, not the county's funds or the city's funds, those private investors will then have to be able to support, this project if it's not successful. So they're at risk on this. So that's a real quick overview of how the funding on this works. Now, the decision that we're asking you to make is we're recommending that we commit $400,000 and then that we sit down with ECHO, the sponsor of the project and the leader in this arena, to then negotiate the rest of the terms and the metrics and how this would work. We would also need to bring our partners to the table. What they're looking for is really $1.2 million. And if you look at the slide here that's projected, there's a circle that's drawn around a portion of the healthcare initiatives budget, and you'll see $500,000. And so what we're saying is, or asking is that we would commit $400,000 out of this $500,000 allotment from the central health budget, and that we would work with our other partners to try to fill the gap up to 1.2 million. Now, I'm also advised that there are other philanthropic sources that could also add additional funds to this. And of course, we would certainly sit down and work with those as well. If the board decides, and I'll be upfront, if the $400,000 is not augmented with other partnership funds or other philanthropic funds, then this does put the project in peril, in the sense that they have to go back and scale this down, or they have to go find other sources of money, or it throws off the time frame. And if they can't do that, then honestly the project probably, and I'll let them speak for themselves, but it's questionable about whether or not it would actually go forward at some point, depending on how this affects the finances. If the board feels like we want to do $1.2 million, then there are other sources from which we can pull. And off the top of my head, it's the healthcare services expansion budget. There's $2 million. We've allocated $200,000 to the Lone Star Circle of Care expansion in Jonestown, I'm sorry, in Jonestown. But what that means is that as you allocate these funds from these different buckets within the budget, you're limiting anything else you can do for the remainder of this fiscal year. And you're also obligated to keep funding it in subsequent budget cycles, which means that, potentially, are you putting upward pressure on other revenue sources to be able to fill this? Yes, you are. So there's a comment, I'm being upfront about what the trade-offs are here. So I've tried to tee this up. My recommendation is that we do $400,000. This will, as some of you have pointed out to me already, make it very difficult to work with other organizations that perhaps have brought other proposals forward. But I think at this point we're probably the last entity, at least on the government side, that is remaining to commit on this. And given that we do serve the homeless population, and if we can go upstream and deal with the critical problem, and that is the stability of their housing, are we engaging in a project which we're going to learn something? And this is just my observation. What's attractive about this is that we are learning something. Is this going to stabilize individuals' lives to the extent that their medical care costs less, but their quality of life is better, their family life is better? And I think we're going to learn something from this. And at the end of the day, if the board decides, no, we don't want to do this at some point in time, then you don't do it anymore. But if you don't engage in this and to start to learn, we're always going to wonder, is it just better just to keep sending people to the emergency room and maybe causing other people that are there to have to wait even longer to be able to see, the emergency room personnel, the doctor, to deal with their situation. So it's, I've struggled with this on many respects, because there's just, it's horrible timing, because there's not a line item in the budget that very succinctly and clearly allocates $1.2 million. But I also know, having been privileged to serve homeless people in the pop-up clinics, that's a real problem out there, and we just can't continue to step around it or step over it. So with that, I'll pause there, and I'm happy to answer any questions.
Okay, before we get to the questions, I'm not going to put a motion on the floor, mainly because of the fact that we need to have a little discussion about the dollar amount that everybody's going to feel comfortable with. So I don't think it's probably appropriate to put a motion with a blank in it for us to fill in later. So I will open the floor for discussion and questions. And again, if we can mind our time and then get to whether or not we're comfortable with a motion, we can move forward. Okay? All right. Madam.
Well, thank you. As I have stated previously, homelessness is near and dear to my heart, and I understand the impact of housing and health. Yet, I will reiterate my stand, my position from last meeting. I feel we are we need to address social determinants of health to, first of all, understand what is our space and capacity as Central Health. How do we better serve our community? And we are funding more of a social service, and which I'm all for. But yet, we don't have a position in place as a group. How are we going to, from further on, approach addressing social determinants of health? Yet, I understand the goal of, of paying for success. And all the other entities in the county and the city, they have a public health budget within them. And this is something that we would have to allocate and take away clinical services that we have allocated for our community members. So I am not in favor of taking away clinical services that we have committed to. I'm definitely all for addressing social determinants of health on a higher level and stating where we are as our position in Central Health and how we should fund it. I understand housing, the importance of it. It's in health, but at this current stage and where we are, we have not had this discussion, and we don't know where we stand in addressing these social determinants of health. I don't feel comfortable at this point in time of moving this item forward without having that deeper dive in addressing this need.
So if I understand you correctly, you would not want to put any funding at this point in time on the table until a deeper dive?
And how we, as Central Health, are going to address social determinants of health. I would love to see a line item in our budget that solely is for social services. And in our budget currently, we don't have it. We haven't allocated that current funding. And it should be also a community question. Should we, from now on, provide also social services, and depending on how we are providing for health care, our mission is to provide for health care. I am a big public health advocate, as many have probably know, but we have to do it right and for our community. And I don't want to feel pressured because the city and the county have committed to it. But at this moment of time, I feel we are not doing just to our community without having a collaborative approach in a concrete way. How do we want to address it? Social determinants of health as a collaborative approach within all our stakeholders here. I wish we have a lot, our budget is tight. I wish I can fund it all. It's not about it, but it's really being diligent to what we have already allocated in our current budget.
Okay. Cynthia?
As I've also stated earlier in 2 previous meetings, I'm a firm believer in us taking care of what our statute requires us to do as an entity, as a taxing entity, and that is to provide healthcare services delivery model system for the most vulnerable population, which I know does include the homeless. And with respect to that, I would support providing them, make sure that we have provided them access to health care. I would not I would even consider, let's take them off the MAP rolls and let's make them fully funded comprehensive insurance through Sendero. I would do something like that because I would know that those people, at least those 250 people that I think you all were talking about in this particular project, would be our clients, and they would have access to comprehensive insurance and comprehensive healthcare services, as opposed to a dysfunctional, we're trying to repair the system and we're trying to make it so that there are no gaps. If they had access to something such as what the marketplace offers, then they would have access to that, no questions asked. And we're not outside the realm of what our statute requires of us to do, and we're not stepping on anybody else's toes. The governmental entities that exist, the county and the city, need to get together with all the school district, with Central Health, with everybody else, and come up with a plan, a comprehensive plan to deal with homelessness. There's been enough money thrown at homelessness that we should have already solved the problem. And each of those homeless people, 2,500 about, would have been able to walk away with at least $1 million in their pockets. And so I'm not against this particular project. I'm just saying that we need to comply with what our mission requires of us and the statute, our law requires of us to do, and that is to address the healthcare access issues that they have had a hard time navigating. So if we're going to give them money for healthcare, let's give them money for healthcare. But right now, let the housing entities provide housing for them. Let the other entities provide whatever else is necessary for them, and we will fill the healthcare gap for those people. And so as far as I'm concerned, until we have that full deep dive conversation, and we have had the opportunity to work with the other governmental entities, including ECHO,
Right.
then, and we come up with a plan, a strategic plan, short, medium, and long term, then until that happens, I'm not willing to put in one more dollar.
Got it. Thank you. Sherry?
So I have some specific questions, and I certainly appreciate all the comments that have been made. My understanding is this is money that is not allocated at this time. Is that correct?
That's correct.
Okay, just wanted to make sure that it wasn't allocated for a clinic, because I heard something, but it's not. It is currently unallocated. It's a placeholder in the budget. Is that
Meaning the $500,000
Correct.
in that line item.
Correct.
It's
Yes.
not taking away from any other initiative.
That is my question. Yes, so it is not taking away, because I certainly would not want to take away from any other initiative, particularly new clinics that we're opening, anything like. So this is not taking away. Okay, that was my first question. As far as social determinants of health, I certainly concur that we need to, going forward, and I've talked to Mr. Giesland about this and some other staff, going forward in strategic planning, and in fact in our next meeting, this will be on, I'm planning for this to be on the agenda, but to look at it as part of our strategic plan too, that we have for Central Health, and to roll it into our strategic plan. So I'm fully on board with that. But I'm hearing that this is like the DSRIP projects that we've done, and that's what I really wanted to explore. So with the DSRIP projects, they have been projects that were not always, I think, solely traditional healthcare is my understanding. And with some of the other projects we're doing, for instance, with transportation, but that they are projects that would, some of them solely traditional healthcare, but others would, for instance, cut down by providing transportation, cut down on the number of people who don't show up on our clinics, which when they don't show, then that increases the waiting list. Or DSRIP projects where we did not pay until outcome measures were met. Would this function like that, and would we be able to determine the outcome measures? And Mike, this might be for you.
I'm going to look to Jeff and
Yeah,
say if they're like certain district projects where you didn't purchase healthcare services, I would say in a general sense, yes, but deeper than that.
Yeah, so I think there are some similarities. You're paying for outcomes.
Right, okay.
I think the biggest difference, at least from my perspective, is on the DSRIP side, you have specific outcomes, generally clinical outcomes that you're
Right.
achieving. This is more predicated on implementing a project and performing a project to achieve savings. You have savings targets that you meet,
Right,
and once those savings targets are met, then that's the trigger for payment. So they're a little bit different, but
I
they
understand.
have some
But-
similarities also.
but determining what those savings metrics are, because I understand what Mike said, that this is an opportunity to learn and to see if we can cut down on those ambulances, on those ER visits that we know are so expensive, that if we say yes to a certain amount at this point, that Mike would then go negotiate on what those measures are going to be that have to be met, and and it would come back to us to be satisfied that these are savings measures that, that we feel merit. Is that the way it would work?
Yes.
Okay, then,
And so and I guess to further, would those savings measures be directed specifically at expenditures that we would probably be making in the future? That are yes or no?
Globally, yes.
Okay,
I just, without getting into the details and
Sure.
having had a negotiation.
Right.
I
session,
understand that.
but that's the goal,
That's the
right?
goal.
It's that they would be savings globally. I understand you haven't had the negotiations yet, but in expenditures that we, Central Health, would be making through very expensive medical population, namely the homeless, who we know cycle through so much with the ER and whatnot. Okay.
And so I guess I would ask you, Sherry, are you for the staff recommendation? Do you want another number besides the staff recommendation?
Well, I would not be for a higher number, if that is your question.
Okay.
I tend to be rather conservative on the fiscal side.
Okay, thank you very much. I'll speak next. I agree that with everything that the members have sort of discussed so far, it is taken from a line item of new initiatives. That line item has $500,000 in it. I am a little uncomfortable with 400,000 in the fact that I think that we could probably learn just as much from 250,000 and allow ourselves another 250,000 if we need it in the future. That comes from my conservative nature also. But if the rest of the members don't necessarily see it that way and would like to go with the staff's suggestion, I wouldn't fight that. So that's where I stand. Dr. Zamora.
Dr. Chair, thank you for the floor. I understand Maram and Cynthia's concern. But as someone who practices in East Austin and frequently finds someone under overhang in the morning when it's cold and it's wet, and I have to chase them away because patients are going to be showing up pretty soon, I understand that homeless issue. So I'll be brief. I'm going to go with the staff recommendation, although my heart says 1.2 million. But I'm going to go with staff recommendation of 400,000.
Okay. Thank you, sir.
I have a few questions. This is a lot of money. 1.2 million ultimately is the goal. And you divide that by 250 patients, that's $4,800 a patient. Seems pretty high to me. And it seems like if we start going down this path, I think I heard you right, but I'll let you clarify that we are committed to keep going down the path. It's not like we can invest $250,000 and say, no, we changed our mind.
That's a good, and by committed, you're not legally committed. In fact, you can't bind a future board's decision on their budget.
Correct.
But there is what I would call is, it's a public expectation that the boards will be there, subsequent boards will make those commitments.
So that being said, how do we measure this? Is it every ER visit and hospitalization? We are looking to eradicate all ER visits or is there a certain number we want to decrease by? I mean, it doesn't seem specific, so it doesn't seem like the specificity, I can't say that.
Specificity.
Thank you.
Specificity.
Thank you. It doesn't seem like that's there for me to make to make an informed decision on. And then I have to say this is the operations will be provided in part by private investors. I would be interested to know who they are.
Right.
And if there's a profit embedded in their investment, are they expecting to seek some sort of return? I think that's fair for us to evaluate, because I would certainly not be in favor of adding a profit layer to these costs. So my inclination tonight is there are too many, and I tend to agree with Maram and Cynthia on this. I think there are too many unknowns for me to commit any dollars tonight. Healthcare services, that's one thing. We can absolutely and we should be providing healthcare services. when we venture outside of that scope, when there are too many questions on the table, I think I'm far less likely to move in that direction and commit us to spending things, especially when I see the very first thing under new initiatives is cancer. That's a hard one for me to ignore.
And women's health.
And women's health, yeah.
So I think probably the best way to begin answering the questions, if I may.
Shannon,
I'm sorry?
Shannon hadn't spoken either.
Oh, I know. He's
addressing
going to
Julie's
address,
question.
Mike, you're going to address
Yes, sir.
Manager
So,
Howard's question.
Mr. Chair, if it's acceptable, I'd like to ask Ann Howard to come up to, I think, start to address Member Oliver's questions. And I think there might even be some follow-up subsequent at the next board meeting, depending on what this committee ultimately recommends.
Okay.
But the questions would be, how specific are the metrics relative to the medical savings or the medical services rendered? Then is there, and few investors make investments without wanting to see a profit. And then ultimately, how do those investors get paid on the back end of this? Good.
Good questions. Ms. Howard, could you please take the stand for us and maybe address some of these questions? No oath needed.
Oath needed. Well, thank you very much for your time tonight. My name is Ann Howard. I'm the Executive Director of ECHO, the Ending Community Homelessness Coalition. We've been working with the staff at Central Health and Seton and Travis County and City of Austin, and once the CCC was formed with the CCC, on this project for several years. And to answer, your question specifically, at this point, you guys would be approving a dollar amount, and we need it to be close to 1.2 million, and that's leveraging, the city's already agreed to 1.2 million, the county's agreed to 0.6 or 600,000, and we also have two large nonprofits that are gonna also commit to 500,000 a year over the life of this project. So, which is, 2.5 from the Episcopal Health Foundation, maybe a similar amount of money from the St. David's Foundation. I don't know that that's for sure. So your 1.2 is leveraging all that other money. We also have then we'll be recruiting the private investment. And the private investment is so significant, it gets spent. That's how we get folks into housing and wrap them with the support services, connect them to health care, make sure that they're staying housed. We use private investment money to do that. Only then, if we hit the outcomes that you guys will approve when it's time to sign a contract, we're really doing this. We've already been going back and forth with Dr. Mark and Sarah Cook and others, for a couple of years about what would the metrics be. And right now, to conceptualize this for you, we'd be looking at a reduction in ER and a reduction in, unnecessary hospitalization.
What does that mean?
It means going to the hospital because you're cold and hungry. It means going to the hospital because you have unmanaged disease, that if we could connect you to a medical home and get that diabetes or whatever is under control, you no longer are using the hospital for your medical care. You're maybe being seen at a clinic. It's replacing the wrong type of care from the wrong location with the right type of care. Okay?
Can that be documented?
Oh, absolutely. So the private investors have helped us make this happen. We've got an agreement with you on what we're trying to deliver. Let's say reduction in hospitalization. We're also trying to deliver reduction in jail bookings, and we're going to deliver housing stability. We're just going to keep them housed. That's what the city wants. Get them housed and keep them housed. Because statistically, we know all this other good stuff happens. But so we will have a third-party independent evaluator paid for out of all this money that I'm talking about, that will then measure using the ICC data or your data or whoever's data y'all agree on that we're going to use to track those individual health outcomes. And we can we can track a whole host of outcomes, but only agree on a couple to trigger the payment, if you will, that success payment. And so then when the third-party independent evaluator says we hit the metrics, at that point, we would invoice you or take the money from the reserves to pay back the investors.
Or,
The investors, like we have support letters from Goldman Sachs, from Bank of America. This will be the first project like this in Texas, but it'll be about the 5th project to do, this type of pay-for-success model, looking at health outcomes and criminal justice outcomes for the chronically homeless.
is there a profit embedded in?
So so yes, but let me tell you about that. These are private investors that are looking to impact health and well-being in the community. And so they're looking for you call it a mid-single digit return. And they often apply that money right back into the project. We also have money from the nonprofit, the foundations committed to this project. And Nirav could speak if we want to let him, that we could, if we had to, that's how these projects work. But if you were going to tell us your money can't make a return, it can only pay back the principal, if you will, that we used for those services, I would assume we could use the private investment, the foundation money or something like that to make that return. But all of these pay-for-success projects are based on, investors.
Any other questions for Ms. Howard while she's up there? Go ahead, Cynthia.
Yes, I like the idea of paying their premiums for marketplace insurance. I like the idea of them working with our existing partners, Community Care, Sendero, whatever plans we have in place. They would have comprehensive insurance for the first time in their lives. They would be able to go to the hospital, to the doctor. They would have behavioral health, mental health services provided to them from all our partners and entities, because the Sendero plan is a very good ACA plan. It has the most that I've seen as far as mental and behavioral health programming embedded in it. And so if we, the public, are truly interested in, and we as Board of Managers are truly interested in making sure that they have that access to all the continuity of care that a comprehensive plan would offer to them by all the entities for all their needs with respect to health care, which is what we are responsible for, then would you not support we paying the premiums for them? As opposed to let, some nebulous possibility of the pay for success would work, will not work, will work to a certain extent, develop the outcomes. I would rather I know that they would have access to health care. I would know that they would have access to primary care, to specialty care. I know that we would be giving them everything that we could possibly give them that they wouldn't get on the street with respect to health care. And that is our role in this county. And that's our role per what the statute requires of us. Would you support that?
I don't know that I know enough about all of that to support that. What I can tell you is that this is all about, taking clients who sort of have access to little bits of stuff and getting them off the street, getting them housed. Your money's not paying for their housing. Your money's only paying if we deliver the outcomes that you were looking for. And that would, that depends on a healthcare system where they can access healthcare.
Well, the ACA, Comprehensive Health Insurance, is a system that they can access, equal to what you may have. Not what I have, but what you may have. And I would rather that they have access to that so that they can get those care needs. What if they have cancer? What if they develop diabetes? They would have all their needs taken care of in a comprehensive healthcare plan.
Okay. Dr. Hernandez, I think, wants to make a comment, And then I haven't forgotten about you, Shannon.
Thank you.
I'm gonna let you chime in once we finish this dialogue.
You won't believe this, but I only have a brief comment.
Thank you very much.
The brief comment is this. When we've looked at MAP data, so in MAP patients, they have access to specialty care, primary care, all the things that you guys are well acquainted with that comes along with being a MAP patient. And we look at the MAP population that is homeless versus the MAP population that is not homeless. And you look at their costs. And by costs, I'm using a proxy. It's called utilization. It's how much healthcare services they utilize,
Right.
which we turn into dollars because it's convenient to talk about utilization in dollars. It's twice as much for any level of severity of the patient. So when we look at individuals who have no chronic illness, if you are not homeless, it's about $1,400 per year. And if you are homeless, it's about $3,000 per year. If you have one chronic condition, then your costs are roughly $3,600 a year. And if you're homeless, it's about $7,800 a year. And if you have two or more chronic conditions, but you're not homeless, you cost us about $7,200 a year. And if you are homeless, you cost us about $15,000 a year. So homelessness is the difference. What I would offer you is that no amount of us clinically delivering services to those individuals seems to blunt their utilization. We're giving them the exact same program. The difference is that one group is homeless and one group is not. And so I will offer to you that the cure for the higher utilization and the worse health outcomes, homeless people, chronically homeless people tend to die about 20 years younger than individuals who have the same disease sets but aren't homeless. The cure for homelessness is to home them. I am not offering who should do that. But I will tell you that from a clinical delivery of services standpoint, I can't create a healthcare delivery system that can outweigh the negative impact of homelessness in these individuals. And so I would suspect that in the absence of giving these people homes, we will continue to see hyperutilization and increased expenses. That's my only comment. Thank you.
Excellent. Thank you, Dr. Hernandez.
Are y'all working with the,
Cynthia? Okay. Any other questions for Ms. Howard? One more question. Please.
Walter Moreau gets money from us to Foundation Communities, gets money from us to do enrollment into ACA. He also bills housing for homelessness. And I would just want to know if you have spoken with him or whether your group would speak with him to see whether or not you all could include him in your project, because he does that as his mission.
That's a bit off topic because we're talking about homelessness and
housing.
ECHO project.
And affordability.
I understand that. Did you want to address that, Ms. Howard, or not?
Oh, I'm happy to. We work with Foundation Communities every day. We also have, worked with United Health Care to get to search the homeless population to find clients who are actually on their rolls and get them connected back to United Health. We also have a very active SOAR program, which is the Social Security Disability. It's a way you apply for benefits for clients. We work closely with Integral Care on all these initiatives to get clients connected to benefits. So, all of this is being done, and I know you can't see the details, but all the orange is the cost related to health care for the homeless population, and the little bit of other color is the criminal justice and shelter costs. So, it is significant, the savings and cost avoidance that this project promises to deliver for, that connects to your mission.
Thank you so much, Ms. Howard.
Thank
Really
you.
appreciate it. Thanks for the information. Shannon, last but not least, of course.
Yes, but I take a position that this is something that's somewhat of a no-brainer. Our mission is health. Healthcare is part of that mission. When we have the data that clearly talks about large percentage of our costs being driven by a certain population, it makes no sense for us not to be able to look at a strategy to address this. True, this does not solve all the health care problems we have in our community. It is a model. And I think that one of the things the taxpayers expect of us is to look at models to be able to address those issues. Homelessness in Austin is a significant issue. And though 250 may not seem like a lot of people for a pilot, I think from the information that was provided by Dr. Hernandez, we know those 250 are drivers of significant cost in this community. Healthcare is not just the only issue that we face as well. Our mission is healthcare, but we cannot address healthcare just by providing healthcare. We've got to make sure that people have environmental conditions under which they can thrive to be healthy. Housing and addressing homelessness is one of the greatest opportunities there. Unlike other districts around the state where they may or may not be involved in this, we can set a model for this. The Pay for Success model I have seen and I've participated in my previous job with the city, and I know it is a model that will work. Not every area, but homelessness seems to be particularly one. I want to highlight a couple of things that were mentioned. Emergency room visits. For those who've had the opportunity to go there and visit there and talk to EMS, we know that that is a significant cost, not only for us, but also for EMS. We know these are repeaters. These are the same people who are constantly utilizing the system. So if we are able to intervene in that system by providing resources that would, in a holistic approach, address their employment, their housing, and health needs, I think we go a long ways to setting a model for us addressing this as a holistic. I would venture that the $500,000 that is proposed here is a good start. But if we have funds available, remembering that this is not something that we have to allocate we have to provide until actually demonstration has occurred. I believe that the work that has been demonstrated in this model can do that. And so I would encourage us to consider, as a step of faith and investing in our future of our community as taxpayers, that we look at measures that we can cut down those costs holistically. Because the taxpayer are paying not only us, but they're also paying for criminal justice systems and others. And so we need to look at that holistically as we decide how we want to go. So I encourage us not only to consider the 500, but I would be one who would go out further. 400, but the 1.2.
You'd be for
I would strongly encourage that as a model for us to consider.
Thank you very much. Mara?
Well, I want to echo what you said. I am definitely a firm believer of housing, but I just want to look at us from terms of central health. If housing is our goal in addressing what we wanted within our framework of addressing social determinants of health, if that's the only thing that we want to fund and support, I'm for it. But there's also we have to look at, are we also going to be able to fund other initiatives? That's my question in addressing social determinants of health. So within the capacity that we have, would we be able to?
Understand. Sherry, brief?
Very brief. I find the data that Dr. Mark just provided very compelling as far as, and my understanding is that we only pay if the negotiated outcomes that Mike Giesland negotiates and comes back with us to approve, if those are met, and that those are specific healthcare outcomes that would lower the healthcare costs that we're paying for the homeless individuals who he has not been able to find any intervention to lower those costs that are double of the non-homeless. Am I understanding this correctly? Okay, I did find that, Shannon, very compelling, as you did.
All right.
Can I just
Sure.
respond to my colleague?
Shannon, go right ahead.
Well, I agree with you. We have a lot of demands upon us. One of the critical components, particularly of humanity, is a point in which person has a place to reside. We have in our community almost 7,000 people who are sometimes permanently or otherwise homeless. If we can begin to set a model, which this would be, in which we can address it, where we have all of the wraparound services that address those social determinants, then we can use as a model to grow other components of what we look at when we talk about the social determinants as well. So I'm saying that this is not the end all. This is a beginning effort to try and address that through a model plan.
Well, you know, it's really heart-wrenching seeing the homeless out there. And every time I pass by, I'm literally in tears. So it's not something that I'm not supportive of, absolutely. I would, you know, it just tears me apart seeing them out there in front of us, and we're here advocating for health. And I always tell Ted, I don't even like the hashtag healthcare for all, it's health for all. It's not, it's just really diving deeper as a collaborative approach to addressing social determinants of health and housing. Maybe this item, it's a wonderful initiative, and I agree with you, Dr. Hernandez, and I agree with you, Ann. It's nothing really, but I want us to do it right, and being good stewards to our tax dollars and really providing them as many services as we can. I definitely understand the high utilizers and the impact that they have, and a person without a home is a person without anything. And I would definitely support initiatives similar to that, but I just want us to be very cognitive of the fundings that we have and how we can better approach the strategy as a collaborative initiative across all our stakeholders and our partners.
I appreciate that,
Yes,
Madam.
we all agree with you.
Cynthia, very, very brief.
It's just, not only am I very familiar with the homelessness of the adults and the children that are on the streets, but I have worked for decades as an advocate for our children and our families that are homeless, that get services through the schools and through other resources. I've been there and done that and with them. And so it's not I'm not pleased to say that I wouldn't support funding them right now. That's not it. I think that, as Maram said, and as I have said in the past, I think it just needs to be done with a discussion of all entities at the table, with the development of a comprehensive plan. There's been many, many years that this has been the subject of discussion. And I think that it needs to be solved, and it needs to be solved quickly. It has not been for decades. And I think that all of us should be supportive of that. And as we are at the table, we look at what it is that we can realistically fund to make sure that we are impacting that closing of the disparities gaps for everybody that needs them.
Thank you.
Dr. Chair, I think we should go ahead
Okay,
and close.
Mike wants to make a couple of,
I was just going to go back. I love what you had to say, but I don't see in this proposal that we have wraparound services. And I just think there are some gaps we need to fill. And I'm still not comfortable with the private investors' profit embedded component. That's it.
okay.
Done.
We're at the end of our time. Okay, we need to wrap this up within the next 5 minutes.
I have a 20-second couple questions, because I
I will recognize you, sure.
do share some of your concerns. Would it be possible to direct Mike Giesland, because we can direct, you know, nothing will happen, at least it's my understanding, unless we approve of the outcomes. And if we, as Ms. Howard said, if we don't want our funds to go to something where investors are getting payback, that we could direct that as part of the negotiations?
It's the board's prerogative to direct the CEO.
And you will, if you could draft a motion to that effect, then I think that would be inappropriate. Cynthia, we need to go on.
I was just going to ask if we could move this to our full board meeting.
That could be a motion.
Give it 1 week.
That could be a motion also, but I'm not accepting motions just yet.
Okay.
Okay? Mike?
Yes, so, again, to summarize this, we're asking for a recommendation to the full board for the $400,000. and I didn't want to begin investing the time and the energy in determining what were the metrics going to be, because as pointed out, this has been going on for a couple of years. Before I dove into this, I needed to know from the board, what's the funding threshold? Because if it wasn't going to be there, I wasn't going to begin investing the time and the energy to getting into the data rooms and figuring out how tight can we make these metrics. I don't need anything mushy. And so I think once we know that's the next order of business, should ultimately next week the full board adopt this. Thank you.
Shannon?
A question for Mike. So if that parameters is the 400,000, I guess the question I raise is, what impact will that have on what we have in front of us in terms of being able to accomplish what has been asked for? Because this is a partnership, as I understand. The question is, will that impact the relationship, the partners that are part of this effort, the city and the county as well?
I don't know how it will affect the city and the county yet, because we would have to go fill the rest of the bill to get up to 1.2 million. And really, I'd have to turn to the project sponsors to be able to answer that question, but that's, you're asking a great question, I just don't have an answer for it.
Is it possible to get because that would determine whether or not we should even go down this road or not, if it will impact that. If they're saying that they cannot participate in it because we're not to, or we're not going to be to a certain level, that would be, I think that would be important.
But they already voted.
And I definitely think that, you know, in the course of any subsequent negotiations, and let's fast forward, let's say the board adopts whatever recommendation this committee puts forward next week, then we could certainly make that one of the front-end threshold conversations that we have in negotiating these terms, which is, city and county, what are you going to do if we don't come up with the full 1.2 with other contributions?
Okay. All right. I'd like to end discussion at this point in time. I would like to ask any of the members if they would like to offer a motion for us to vote on. So,
Can I offer one?
Autumn?
Can we move this agenda item for our next board meeting while all of these questions have been answered? Not to make a decision now, till next week.
Okay, so the motion on the floor is to table the item
Right.
until the next board meeting,
Which is a week from today.
which is a week from today.
And would we have some answers back to what Mr. Jones had,
All our questions
to our questions, our concerns?
Mike?
within that time.
I don't think that I will have all the answers, because part of this is starting the negotiation process so I can get in there and see how this is going to look and work. And like, for example, I don't know that I'll have the metrics question fully answered by the next board meeting. I will by the time I bring a contract back to the board for you all to approve. And with respect to Shannon's question, I think we could probably have some quick calls go out, even if you move the recommendation tonight, by the time we get into the next board meeting, to know what will the city and the county do if we fund it at 400,000 and can't get the rest of it filled.
So how about to the next budget and finance meeting? Would that be,
Are you changing your motion now to say table it until the
if we don't have sufficient time?
Well, we have to have a vote on the
on the
original
first one?
motion to
Well,
postpone.
I need a second.
Are you amending
All
it?
right, so
There was
is
a second.
anybody seconding?
I'll second it. I thought,
Cynthia?
you didn't second it?
Oh, I didn't second.
Oh, okay.
Discussion.
But I will second the one that says,
Seconding.
What are you seconding?
I'm seconding her motion.
Is her motion on the floor is that we move it to the next budget meeting, to the
Board meeting.
next
Board
board
meeting,
meeting,
which is next
which
week.
is next week.
I would suggest that you don't second it, let it die, and then we can bring up another motion.
Do a different one.
Okay, so we actually,
I-
let's limit, we can't have discussion on it. So,
Right.
motion, second.
Second. All right, but there's no second. So she will not second it,
Okay,
okay? So the motion fails,
yes.
okay? Now, I'm looking for someone to offer a motion, hopefully that we can all agree on.
So can we,
Anybody? Shannon?
I want to make sure I know what I'm motioning, because I'm in favor of moving that we accept the recommendation put forth by by staff,
Okay.
that we vote on it at the next board meeting.
So then you would make that motion again.
Okay, so your motion is that we accept the recommendation of the staff and recommend further discussion at the next board
The
meeting?
next board meeting, yes.
At the board meeting.
So that would be, you would be making a recommendation tonight to the full board to make the commitment. And then what would happen is we could place this on the agenda for next week for further discussion with the understanding that this would be an official recommendation from the Budget and Finance Committee tonight.
So it would be an official recommendation from the
Right.
Budget and Finance Committee to the full board.
Yes.
And in essence, it would be put as a regular agenda item, not a consent agenda item. And we would discuss, it would be brought up again for discussion.
We could put it on the regular agenda instead of the consent agenda. And if you wanted to make that motion, it is on the motion sheet to make the recommendation to the full board.
That item what?
Item 3.
Item 3.
And that would be the first motion if it was at the staff recommendation of $400,000.
Well, in order to, my consensus of the board is that that's going to be the max we can get out of this board right now. So I move that the committee recommends the board commit
$400,000.
$400,000 of new initiative funds to Ending Homeless Coalition Permanent Supportive Housing Project expected to reduce emergency room visits and hospitalization rates among homeless in Travis County.
Second.
Okay.
Now we can have a discussion.
I have a motion and a second. Now we can open it up for discussion. Shannon?
I think it's important that we move this along. I've heard here that we've discussed this for quite some time. I'm only new, this is only my third board meeting. And the fact that we've had this for quite some time, I just think we need to move the process along. I think the data has been provided, the information. I do think that we need to provide the answers to the question that the board members have at that meeting before we make a vote on it. But I do think we need to make a vote next week, no later than, at the board meeting, which is next week. Oh, that's why
So,
Okay. Sherry, I'm sorry, and then I'll get to you.
okay, so this is, from what I understand of your motion, it is a recommendation to the board of the 400,000, but it's not any kind of binding vote. So if this is approved at the board meeting, there could still be changes, right, in the amount. There could be direction given in the form of a motion to our CEO as far as negotiations, correct? All that could happen in our board meeting a week from today, is that correct?
That is correct.
Okay.
Okay. Julie, I'm sorry.
It sounds like Mike will not have all of our questions answered by next week. And I think I will not support this until we have questions answered.
Got it.
And I'd like to also say that this is only the second time I think we've even had a discussion about it at the board. I don't know how long staff has had it, I don't know how long the city has had it. This is only the second meeting that we've had it here, so it's not like it's been sitting around for years and years here.
It has not.
She means at the,
At the
board level?
At the
No.
board level.
Board level for discussion.
It has
But
not.
I hear,
Yeah.
so this is only the second time that this has been
Yes.
presented
Correct.
before this board?
That's
Yes.
correct.
Yeah, you were here the first time it was presented.
So it's relatively new.
Excuse me. All right.
Dr. Chair, again, thank you for the floor. You know, the chairman position is much bigger than I am. The CEO position is much bigger than Mike. But several years ago, before you came on board, the board then decided that only the CEO and only the chairperson as well may. So I do not agree with the motion going through if we're going to vote. We're going to discuss it again next week. As I said last week, I really want these things to go through committee
Right.
before they get to the full board. Otherwise, we're going to have another board meeting like we did last time. And that was what my whole memo that I sent out this past week was. Let's get this stuff done at committee levels, not at the full board. Otherwise, we'll be there till 11 o'clock at night.
I got you.
Thank you for your time.
Should we just call for the question?
Okay,
Call for the question.
calling the question. Do we need a vote on that?
The third vote.
Okay. We have a motion to call the question. All in favor?
I'm sorry, Mr. Chair, but, Dr. Chair, what are we asking for? That we bring
To
it
call in the
back?
question for his motion.
That means to end
End
discussion
discussion on
on
manager.
Shannon's
Just
motion.
to end discussion, or are we bringing it back next week?
Okay, so the question that Dr. Zamora has, the motion that you made was actually a motion that didn't include bringing it back, all right? Because
Like a substitute.
you read that this was a recommendation by the Budget Committee.
Right.
Okay? All right. But Sherry recognized that what you had said before, that it would come back to the full board. So I'm going to ask, well, first, Sherry, you want to clarify what you?
Well, I want to make sure I'm following what everyone,
Of going
the
on.
sequence and what everyone has said and their desires. What I'm hearing is that the motion that was made was that the 400,000 be recommended to the board. But then I subsequently heard from the chair of Central Health, who I deeply respect, that he does not want to have those type of further discussions at the level of a board meeting, which would be next week, that he wants it to be at the committee. So it seems to me that those two are conflicting. And I'm thinking, and I don't know if my colleague would be amenable of a substitute motion or an amendment to his motion.
Let me just, for clarification, whether or not this is on the consent agenda next week or the regular agenda, any board member could pull it from the consent agenda, so it will be ripe for discussion next week regardless.
Okay. So.
Yeah, I understand that, but I think I heard our chair say that he doesn't want things going to the full board that are going to have a lot of discussion. Is that what I heard, Mr. Chairman?
So your amendment?
Well, my amendment, but it would be a very different, I don't know if my colleague would agree, would be that we bring it, I guess, back to either, I guess, to this committee,
Budget and Finance.
Budget and Finance, so that there will be time to have my colleagues' questions answered, so that we can.
Ms. Howard, would you? Ms. Howard?
Yeah.
Ms. Howard, would you like to come up?
Yes,
to the-
if there are answers now, can you both please come up to the table?
No notes.
Okay?
And can I get you to introduce yourself?
My name is Ann Howard. I'm the executive director of ECHO.
My name is Nirav Shah, Vice President of Social Finance. We're a nonprofit that develops and executes Pay for Success projects.
Great. Go ahead.
A couple of questions that I've heard is, one, what happens at $400,000 compared to the 1.2 we need? And with the idea being we could go maybe get that money from other partners. And I think those typical ones would be Seton and St. David's would probably be what you might be thinking. And, you know, all along, we've been talking with the CCC about funding this project. So I think it's possible that we would get, you know, funding from Seton or the CCC. But at $400,000, it's pretty low. You know, I'd feel much better if it were $600,000, and if we could get Seton or the CCC to contribute, then we know we've hit our 1.2. St. David's Hospital, we have met with them over the couple of years we've been working on this and not moved them to come to the table like this. We've also explored Scott and White, and at the time, you know, they were brand new when we talked to them the first time, and they said, you know, maybe later, but we don't have local hospitalization and stuff like that. And so, you know, the $400,000 figure, if that's all we get, and we don't get money from Seton or anybody else, that we would be basically starting over. I mean, the lion's share of the cost avoidance from this program is healthcare costs. And so to all of a sudden have Travis County Criminal Justice Planning's paying in a bigger amount and the city paying in a much bigger amount, like, it just throws the project in a much, we'd have to sort of start over with the negotiations. And that's where the time, we've spent tremendous time working with staff across the community to put together this sized model.
Can I ask her a question? So is this the first time you've had the opportunity to present this to this board?
Yes.
I actually was here and presented on this project. Remember y'all all said I did a really good job, Stephanie, I can't remember when that was. Last fall. We've presented to the CCC board. We've presented to the Healthcare Alliance. We've also secured a federal grant from HUD DOJ for $881,000 that'll be contributing alongside with your money should the success payments work. Trish signed on to that grant. We've been in partnership with you guys, at the staff level for a long time on this. I think you had some other questions, Nirav.
Yeah, I'll try to rattle off a couple, then tell me what I missed. The metric that we've talked about, again, it's not been finalized, is again, reduction ED hospitalization for unnecessary costs that are avoidable based on permanent supportive housing. So diabetes was cited, individuals coming in for sobriety reasons. Those are examples of unnecessary costs that would be part of the healthcare metric. So I think that was one question. Another clarification is that we are not asking for an obligation of funding at this point. This is money that's put aside for this project. The contract would have to come back to this board, if I understand it.
Right.
And it's that point, then funding would be obligated. So just to clarify kind of the cash flow component of this, and again, as Mr. Giesling mentioned earlier, the outlay of this funding would not happen in 2018, because the outlay would only happen if there's a reduction in ED and hospitalization based on the terms of the contract that, again, this group or some version of this group would have to agree to. I think that was one of the questions. On the investment.
Can I stop you?
Please do.
So if Mike Giesland went and let's just do a scenario. He goes and negotiates with you. He has to come back to this board. That's what, because of the amendment. So he comes back to this board, and this board, if this board is satisfied, says yes, sign the contract, and then we're obligated for $400,000. If this board is not satisfied, then we say, no, don't sign the contract, and we are not obligated. Is that correct?
That's right, and that'll be true. City council will have to approve it. County commissioners will have to approve it, and the private investors will. It's a big contract, but your money today would allow you'd set it aside, you'd earmark it, however you operate, so we can go create that. We know the scope of the project. We know that we're trying to. It's going to be for 250 or 220. We know that we then go raise the private investment and get them in on the contract. Without your money sort of earmarked, we can't go raise $17 million. We can't create a contract if we don't know what everybody's, aiming to be in for.
Ms. Valadez, did you have a question?
I'll let Moran go in then.
Mine is really quick. Mike,
Yes.
has this, on the staff level, have they been in coordination with the city and county on this project, or has it been just every entity working silo on their own budget? So
we've had bi-weekly or monthly phone calls since the city council passed it in September. Yeah.
Rob, who did you direct the question to?
I'm sorry.
Sorry, I'm just trying to, have your staff, have they sat down in the same room with the city and the county to discuss this item? Because it's a collaborative approach, it's not just us. I just want to know.
In a high-level meeting, it's my understanding there's been some interactions at the CCC staff level with ECHO to the extent that they've met with city and county. I'm not advised yet.
I'm just curious.
But again, that's part of this process to get before I start spending the time and energy to negotiate all these things and going back and figuring out what's been done in 2 years. That's part of the next order of business.
Ms. Howard?
Stephanie Hayden, the interim, who now is the director of Austin Public Health, she was tasked by the council to lead the collaborative meetings since, September when they passed their budget. So we've had in-person meetings out at Levander Loop and phone call meetings. Typically, Sarah Cook is the one who was tasked to be on those calls, and she has been negotiating with us the outcome metrics. We've done a lot of whiteboarding, looking at the data. The data comes from the ICC. We've looked at the Wakely data, whatever that is. I've gotten gray hair over this project, working with, the community staff. This is, you talk about a collaborative. This is a collaborative that's rich with wraparound services. We're not going to have anybody in this project who doesn't have groceries. They're going to have transportation. They're going to, we talk about education, and I mean, this is a sort of like the Cadillac version of how you do support services to keep folks from returning to homelessness. And their improving health is just a huge part of that.
And there'll be medical professionals on this assertive community treatment team.
That's the model. It's in partnership with what Integral Care is already doing. We'll be expanding that type of model where there's peer support specialists and substance abuse specialists, and anything those clients need to keep them housed is what our providers will be on the hook for providing.
Did you have something additional question you wanted to address, or did Ms. Howard?
Not on this topic, but I think there was another question around investors, which I'm happy to address briefly. So there will be private investors who are putting up the upfront working capital, who are going to spend the money for the assertive community treatment team. So the wraparound services, the housing money is coming from a separate source. So the investments are going to go into directly the wraparound services, and they can come from a variety of investors, from foundations, from community development financial institutions, from high net worth individuals, or financial institutions like Bank of America and Goldman Sachs. There is a modest rate of return for this, but I would also mention there is significant risk, because if the outcome metrics are not met, Central Health doesn't have to pay anything. And so the investors are losing their investment. So I think you have to think about both of those aspects together. Governments routinely use investment dollars to do their business through the issuance of bonds. I don't see this any different in that. The only big difference is that there's not a guaranteed payment on this pay for success vehicle. It's payment contingent upon the achievement of outcomes. So I think that was another question that was addressed.
So we have a motion and a second on the floor.
Can I ask one more question?
You
while
can.
we have them?
You can.
How are they selected? Because I think it makes a big difference if you're picking people who are probably maybe temporarily homeless and would have higher rates of success in a program such as this, and people who are
Chronically
homeless with more severe issues.
So I've worked for the last 6 years to move the community to serving the most vulnerable with the highest level of acuity. So we already have a whole coordinated assessment process where everybody who's experiencing homelessness undergoes an assessment. It doesn't matter where they are in the community, and we use an open and shared database, and all the nonprofits are housing from the top of the list, the most vulnerable. With this project, we get to layer on top of that vulnerability score their utilization, what Dr. Hernandez was talking about. So now we're going to look at, in fact, we've already pulled some data around like the top 800, the top 500, and looking at that utilization and finding the nexus between the highest healthcare users and the folks cycling in and out of the Travis County Jail who are also on this vulnerability score. So we are looking at the very top, and depending on the type of evaluation we use, will depend on sort of how we're going to determine like who's in the control group and who's in the, or something like that. But this is not a creaming kind of thing to be successful. This is challenging the community to deliver the right services to house the hardest to house and the most frequent users.
And I would just identify that the contract will stipulate, so the contract that again will come, what is the eligibility criteria in order to get services under this program. So the contract will identify what's the eligibility criteria, what are the outcome metrics, how are we going to measure the outcome metrics, what are the payments, what are the payment points, what's the schedule of funding needed from investors, and what's the schedule of funding needed from the different sort of payers, and then a lot of other legal stuff.
What's the rate of return?
Mid-single digits, but again, it's all contingent upon outcome. So if on the extreme scenario you get 0 outcomes are achieved, there is no payment, so they lose 100% of their principal. So it's hard to give one number because it's not like you're putting money into a savings account and that savings account, excuse me?
What are they offered?
They're,
I mean, you probably have to go to them with some sort of offer. What's the range?
sure, so the range is typically you lose 100% of your capital, all the way up to a cap that's typically around 9 to 12%. Is their rate of return. But again, so in order to get to that 9-12%, you have to shoot the moon on the outcome metrics. But you can also lose all your investment if you don't get any.
So that's spelled out.
Yes.
Yeah, the caps are, but again, there's so many, because there'd be 2 or 3 outcome metrics, there's lots of iterations on where you might land in that spectrum. But the cap in total return available and the floor will be clearly identified.
Cynthia, I'm sorry.
I don't know that my question is going to be directed to you two. I think it's going to be directed more to Mike
Okay.
and staff, or Mike. You know, I'm reading here that this is a commitment to support permanent supportive housing, expected to reduce the ER visits and hospitalization rates amongst homeless. We had the district projects. We did fund, didn't we fund a project with EMS specifically under DSRIP to address the emergency room visits?
There was an EMS project, but I'm not sure what the targeted outcome
Well,
was.
the reason I'm saying that, the reason I'm asking that is because I personally would like to know what then I would want to review myself, hopefully in a committee meeting then, the district projects that could have informed or would have provided data that could help the planning for the development of results and outcomes, where they fall in our priorities as a board, how they impact the strategic plan that we have already developed, and had that discussion before funding this project. And you know, I do take great heed in what our chair suggested to us, and he did a good job in reminding us that this is. I really think that we would be better served if we had a full discussion in committee about this project, and if they could be invited to participate, but at least I would like our staff present to be able to talk to us about the results of our district projects with respect to how they relate to the proposed project, because I'd like to see a copy of the prospectus. I'd like to see a copy of the.
Okay.
Of the,
All right, you got it.
Understood, but what you're
information.
talking about is, just to make sure I understand you correctly, I mean, it's basic business diligence and putting together a business case where you
Yes.
have, what's the alternative over here, where you know you've made these investments so you can see what the ultimate outcome.
because I'm most concerned about, you know, we can call it a set-aside. A set-aside still means you can't spend that money, because it's going to be set aside. And I'd like to know exactly what that means. And meanwhile, before we even consider setting aside any dollar amount, I still would like to know how it fits within what our priorities are, what our strategic plan is, and what the results are of our district projects that we have funded to the tune of multi-millions of dollars.
Got it.
Understood.
Now,
Yes.
there is a call the question on the floor.
So that technically failed because
Didn't
it
get a
was
second.
never voted
Get a
upon.
second,
There's a motion and a second on the floor to make a recommendation to the full board to commit $400,000.
Okay. And so, in essence, if the desire, we need to vote on this motion. If this motion fails, and the desire is to rehash this in the next budget and finance meeting, then I need a motion for that. Okay? It's up to the members. So, discussion is ended. We're going to take a vote, and actually, I'd like to see hands on this one. All in favor, say aye, or raise your hand.
In favor of Shannon's,
Of the current motion.
and that is to recommend
To recommend $400,000.
to an additional discussion at the next board meeting?
No.
I thought that's what he
It will
included.
be on the consent agenda.
Okay.
And it will only be pulled if a member requests for it to be pulled. Okay? All against? You have 3, okay? And any abstentions? Okay, motion carries. Thank you very much.
Thank you, members.
Really
I'm going to pull
appreciate
it. I'm just going to pull it.
Let me, so you can pull that agenda item off the consent agenda, Cynthia, but we're just not going to be able to have this robust discussion that you were asking for. We won't have the answers that Mike, you're asking Mike to bring to you.
That's right, and I think that's a consideration. You know, how can we be voting on any amount of money without having those answers?
We hear you.
Okay, I appreciate that.
Okay? All right. Agenda item number 2. Discuss and take appropriate action on the contract between Community Care Collaborative and the Fibroblasts for specialty care referral management. We have allotted 20 minutes for this, and our presenters will be Melanie Diallo, okay, and Dr. Hernandez. Please start.
So thank you guys for having us. We're excited to talk about the progress that we've made. Just personally, this work is one of the reasons that I enjoy coming to work every day. When I think about changes to the referral management and specialty care delivery process, I think about true transformation. And so I'm excited to talk about this and share with you sort of the story of how we've gotten to where we are. We obviously have come to you and talked a little bit about our eConsult pilots in FY16, FY17, and into FY18. You know that specialty care access is a priority for us. And streamlining services for our patients is something that's critical to the work that we do every day. And all of the work that we've done to date has really been a learning process that has gotten to us to the point that we're asking for approval to move forward on an actual platform. As part of our FY18 budgeted activities, we started a very collaborative stakeholder group to really understand what is the need in our system from an infrastructure perspective. And so we had organizations like Community Care, El Buen Samaritano, Lone Star Circle of Care, Seton Healthcare Family, Dell Medical School, People's Community Clinic, come to the table and really discuss how is referral management working, how are we going to get eConsults off the ground, and then what are the technical capabilities of a platform that can support everything that you want to be able to do to deliver clinical services to the patient. And I think that was a really important part of the process, because this was not CCC administrative staff sitting in a room. It was physicians and referral coordinators who were really informing how this needs to work at a system level, and being able to have a voice in the selection process. And we looked at about 12 different platforms. Thank you. Based on the feedback that we got from our community partners, we decided to move forward with Fibroblast as the platform that we're seeking approval on today. And I'll tell you a little bit about why we think Fibroblast is the right choice. One of the major requirements, the two major requirements that we heard from our stakeholders was that the referral management process and the e-consult, provider-to-provider exchange processes, those two processes needed to be connected. And there are very few platforms that do both. Most platforms either only support referral management or only support e-consults. And the reason those two need to be connected is because providers would like to start the referral process with an e-consult. So with the idea that that patient may not need to be seen face-to-face and it's something simple to be resolved by the primary care physician. However, if a specialist and a primary care physician decide this person really does need to be seen face-to-face, they need to have a streamlined way to make sure that that referral moves forward and results in a face-to-face appointment, as opposed to having to copy and paste from one system to another. And so Fibroblast is a platform that does that. It centralizes the referral management and e-consult processes. The second part of that is it provides standardization. The process that we have today is a very, very manual one, and you can see from the slide deck that's in your backup packet, it is a lot of copy and paste from one system to another. For e-consults, for example, you have MAs copying and pasting from a texting app into the EMR and back. And it's just not an efficient process. The other part of it is once you have standardization and a place to capture all of the information you need and support the exchange, you have data visibility. Because the processes are so manual today, it creates a lot of variation in the data. So I was looking at a list of years earlier, and there were 7 different ways to type out Amerigroup. And it's caps here, it's a space here, it's not discrete, there aren't discrete fields. And so it means that when you go to analyze the data, it's really hard to make sense of it. You have people manually counting how many people are in a wait list. And so our hope is that Fibroblast will allow us to configure the tools, and each of the providers will have a say in what the configuration looks like at their organization, but still allow for the standardization so that we can have standardized reporting, so that we can capture the information that we need, and then have greater influence over how we reduce those wait lists. So once we have the awareness and knowledge of what the wait lists look like and the opportunities to continue to improve access, it empowers us and our physicians to help us reduce those wait lists. The fourth part of it is EMR integration. The tools, like I said, that we have today are not integrated in an EMR, so it creates a lot of a high need for copy and paste, so that we have medical records that have current information. I mentioned a little bit earlier about transformation. I think the real crux of this is that we are uprooting the entire referral management system and trying to reorient it to favor the patient. Right now, and I think this happens at many organizations, the referral processes sort of develop as the need arises. And I think we have an opportunity to look forward and work as a community to establish a streamlined process. And so this platform, Fibroblast, will allow us to have interoperability with Dell Med School, with community care, and to share clinical information between providers so that they're not blind to part of the care of the patient when they're seeing them in the primary care home. So that is a really transformative way to deliver care, and to me it's one of the more exciting things that we're doing for patients today. So we're asking for $700,000. It's an existing line item in our FY18 budget as consultation and referral management, referral platform, and we're aiming to spend less than or equal to $700,000 to help change the way that we deliver specialty care.
Thank you very much. Appreciate that. I would like to get a motion on the floor before we open discussion. Chair?
We're on.
Item number 2.
Yes, I had to, we've been a roundabout
We've been
order,
all
so I'm
around
going to
the
make sure,
world.
yes. I move that the committee recommend that the board approve and direct the Central Health appointees to the Community Care Collaborative, CCC, Board of Directors, to approve a contract between the Community Care Collaborative and Fibroblast for specialty care referral management in an amount not to exceed $700,000.
I second.
And we have a motion and a second. Any discussions or questions for our presenters? And I will start with Shannon.
One quick question. You said interoperability between the various providers, but did it also include the city health department?
It could if we would have to ascertain what the interaction of the city health department would be with the software. So when we talk about interoperability, what we're really talking about is integration of the platform into the electronic medical records of those entities that are either providing specialty services to our patients or are referral sources to our patients. That's what we're talking about in terms of interoperability. If we're talking about data, so then if the conversation, and I can't read your mind, Shannon, but if what you're thinking about is there opportunities for the city and others, but we'll use the city as your example was, to utilize that data in framing larger public health initiatives, that's certainly a conversation we could have with the city. I think that could exist here. It could exist inside of other sorts of data sources that the CCC creates. It's just based on a foundation of what are we trying to do together? What is the need of the city or the county for data? How do we help create that collaboration? So I don't know if I answered your question because I can't.
Well, no, I was just thinking between the services, the medical services or clinical services.
Are you talking about, so like TB clinic?
Right, TB.
Yeah, we could integrate those services.
Yeah.
There's no reason. One of the advantages of the Fibroblast client is if a particular provider that provides specialty services to our population is not interested or isn't big enough to warrant a full integration, there's a cloud-based access to the server. So if the volumes are small enough that you're not interested in have somebody come in and implement and muck around in your EMR, there is still a way you can participate with us through this application, just on a cloud-based kind of way. So either or is possible.
All right, thank you.
I think my question, are there other providers, just to make sure that we're getting the best best bang for our buck?
Yeah, so we,
Providers that are similar in scope and.
so the last part of your question threw me. Other providers similar in scope that are using
Yeah,
this product?
or no, the people who would offer this.
Oh,
Other people like Fibroblast.
Okay,
Okay,
sorry. I lost your question. I'll let Melanie speak to specifics if you want them. We had a list of about 12. So when you looked at the initial set of companies or products that we looked at in response to this need, it started out with a dozen. And so we looked very hard at about 12 companies. Several of them fell out because they couldn't meet the requirement of having both the e-consultation platform and the referral platform, but it didn't make it zero. It actually ended up with 3. So we ended up with 3 companies as kind of finalists, and then a more detailed process came into being. That shortlist went down to 2, so we cut 1 off and then did further kind of competition between the last 2 before we decided on this product.
Big difference in pricing or no?
So the one of the options that we didn't actually do follow-up demos for with the stakeholder group priced itself out. And so to your point, we felt like we were getting the same value for less compared to that product.
No questions.
Sure.
Just a couple quickly. It sounds like the current process we have is very prone to error. When I was listening to the cut and the paste and so this will, I hope, and it certainly, I don't know how it could help but not increase efficiency and reduce error in the records, which can affect certainly the outcome for the patients when you have those kind of errors.
And if I can point out something that Melanie did a great job on these slides, but she didn't touch on it here, but I'm going to touch on it for her because I love these slides. Everywhere you see a person, this is current state. Everywhere you see a person on this diagram,
Yes.
that's a manual touch of data.
Okay,
This is future state.
right. And
So yes, we take a lot of the potential for human error out of this new state by automating, which means that you have to have
Wonderful.
people
My next-
integrated so data flows from one system
Understood.
to
My
another
next-
without a human needing to be involved in it.
wonderful, because I think we need to increase efficiency and cut down on errors. Next, it sounds from everything that you said that this will get us down the road to making sure that when our patients, because they may not have medical homes and they're going to different places, that there will be those accurate shared records for our patients. And you can just say yes or no.
Yes.
Okay, good. And lastly, I'm hoping, and this is a discussion I think you and I had when I first came on the board, that will this provide us, and it goes with what Shannon was saying too, the ability to gather all this data and begin to do some future thinking and some predictive analytics to try to further provide better care. Okay, thank you.
Thank you. Manager Valadez.
Sherry, thank you for bringing up at least two of the concerns I had, and that was working with the development towards or going towards this integrated delivery system and this comprehensive, I guess, data sharing component that we need to have in order to plan better and to look at trends and to see where we need to go with respect to serving the needs of our consumers, of our population. So thank you, Sherry, for asking all that, and thank you all for answering that. Was the ICC included in here, and was community care included in here?
Community care absolutely has been at the table and will probably be the first site that we pilot all of this work with, as they are both the largest referral source and a very important provider of specialty care, and so they kind of live on both sides of this. The ICC doesn't have a direct role in this, in as much as the data that they collect around patients that's fed to us and our partners isn't this data. So the truth of it is in the current system, this data doesn't live in an easily abstractable place. The ICC wouldn't have it. This represents a new data source that is ours. And creates a view into the data that frankly nobody has had until we actually stand up this process.
So what it sounds like is what we're doing is we're going to the next generation over ICC, and are they ultimately going to be something we're not going to necessarily buy into because we're going to have created our own?
I can't speak to
our
that.
Population.
This is
I'm just
purely
asking.
around referrals. So this
Different
is
data.
a narrow piece around referrals.
The referrals has all that, the preliminary data on the individual patient that we can continue to follow. It's all going to be there, it's the same data.
Mined out of this process. It doesn't replace a community HIE. That's kind of a different thing.
Yes.
Right.
I will say, I'll take my opportunity to jump in real quick on your comment, Cynthia, to say that, and I hate this term in business, but I'm going to use it. This is disruptive. I don't normally talk about disruption as being part and parcel of what the CCC does, but this is actually disruption. So we are taking a process that we have had for a long time in this system, and we are saying that is not the process.
Right.
We're going to break it, and we are going to replace it with the foundation of a process that really lets us fix specialty care. I have wanted to do that since I came here. You have wanted me to do it.
We have.
This is the beginning of that. So I think this is crucially important. And I actually don't think the CCC is doing anything more important than this. My colleague sitting behind me would argue with me all day about that because we're doing many other important things. But I'm the doctor, so I'm going to believe that this is the most important thing.
Well, and as a patient and a consumer, the one thing that I have been forever concerned about is the increased wait times.
Yes.
We have not seen, very much of a movement to decrease them, except for having to go to these created clinics in the 4 areas to be able to look at that. And even then, we still have people that are sitting on those rosters that have not yet been seen. And this is years later.
This is the beginning of fixing them.
Great,
Okay, thank you very much.
thank you. Madam?
Well, thank you. That first slide that you showed, it's very busy and yet colorful, but I can only, literally amazed.
I was told to use ugly colors. I don't
No, I
know
love the
if I felt that
turquoise
way.
and gold. Very Southwestern.
This is really wonderful what we needed, and I think I've probably asked if we had such a thing, which we did not. Now, looking at our other referral sources, are we including our other clinics?
So, yeah, what's key in this is what we aspire to. Everybody won't get it immediately. There's always phased rollouts to everything. But we're not going to go slow either. This becomes the mechanism by which referrals are created. So any of our primary care providers that want to refer a patient to specialty care will make that referral through this system. And any specialty provider that is going to provide that specialty care to our patients will receive those referrals through this system. And while that referral is transiting from the primary care provider to the specialist, we get our hands on the data pipeline because we own it. And so no longer is there a thing where we don't know how many people are in line or we don't know where people are. We own all of the data at that point. And so that's crucially different. Everybody's included, so nobody is outside of this.
Now, and in terms of interoperability, is this going to be in between outpatients and clinical and inpatient data? Is that, or are we still?
No, this is not meant to fix overall data interoperability. That's
this
a
is
much
just
bigger conversation. This is around the notion of, I have a patient for whom I need to consult a specialist. How do I do that? So this whole slide right here, as busy as it is, only answers that one question. If I have a patient who needs to see a specialist, how do I make that happen? That's how we make that happen today.
So
all
what
of
if
those steps.
one of our MAP patients was seen in the ER? How can we? Is there a possibility of providing e-consult for their PCP, or do we have this?
No, that's
So they
that
would
different
go-
solution.
yeah.
So ER to PCP communication is not part of this.
Right.
That's not part of this structure.
Do we have plans?
I'm not arguing that it doesn't need to be fixed. I'm just trying to stay in scope with what we're talking about, which is this. We have to fix that part as well, Mara, and we have to fix the parts where hospital doctors discharge a patient to a PCP. Again, this is not the solution for that. This is narrow. It deals with e-consults and referral management.
Okay, and if possible in the future, if you can present to us how many patients you referred and at the wait list.
And guess what? We'll have all that. That's part of moving this. Like today, when we want to know those things, it's a very manual process that involves multiple companies. And in the future, this is called reports. A report gets run out of the software that gives us all of that data every day, if we want to look at it every day.
And my last two, when do you anticipate this going live? And the second one, and I was going down to under MAP patients, where specialty, the next slide, specialty providers schedule appointments, and CCC performs confirmation calls. So in terms of patient-centered care, are these appointments based on a patient's availability or the clinic's availability? And we don't want no-shows. I just wanted.
So
How does
I'm gonna
that work?
let me address that question, and then I'm gonna defer to my colleague to answer the first question, which is timetable. On that question, always we try to schedule any patient for any sort of appointment at what is convenient for the patient. What's important here is that patient forward or patient sensitive kind of interaction between the provider organization and the patient itself is largely a function of the provider organization. And from the CCC's perspective, our job is to sit over the top of that and make sure that we're holding those providers accountable to being sensitive to what happens with the patient. Having said that, the challenge in the system for so long has been that if I make you wait 6 months to see the cardiologist, If I have an appointment that isn't really great for you, most patients have been willing to change their lives around to be able to get to the cardiologist if it's not convenient to them. They're just so damn glad they get to see the cardiologist that they change. We got to get better about that. I don't want them waiting 6 months, in which case, if we're talking about scheduling you inside of 30 days or 45 days, we should be able to be sensitive to the fact that Thursdays never work for you, but Monday afternoons are good. And so I think when we begin to get away from this notion of feeling undersupplied, we can become better at being patient-friendly in that way. That's my answer to that one. I'm going to let Melanie answer the timetable one.
So in terms of the implementation plan, one of the things that's really, really important to us is that we do this right the first time around. And we're not going to do it perfectly, but it's really important that we take time with each of our partners to configure the platform in a way that supports adoption of it. We have seen what happens if a new platform is rolled out and all parties aren't on board, all parties aren't properly trained, they have to develop workarounds for processes that are meant to be standardized over here, but they're working over here. And so I think once we execute a contract, the first couple months purely are going to be planning with each of our individual partners. The vendor Fibroblast is going to be coming down for 2 weeks to shadow, to understand what the workflow is, and to figure out how to configure the platform for the needs of each of the organizations. And so I can't say that we're going to roll out on a certain day or a certain month, but that process will probably take a couple of months. To be honest, and Sherry, to your question about data, the data that we have is not good.
Right.
So part of the work that we have to do still is mine the data.
Right.
So that when we do have the platform, we have some good information coming, new information coming through the platform, but also that we can combine it with our old data that we will have to go through manually. So I don't know what the timetable is when we'll be able to report back to you very specific wait times. But I can tell you over the next, 2 or 3, 6 months, we will be going through and combing that data so that it is in the same format that we have in Fibroblast, so that we can populate those automated reports.
I understand.
Report out.
At least we won't perpetuate the bad system.
Exactly.
Thank you.
Cynthia, you
Very
have
quickly.
2 minutes and 30 seconds.
So I understand data in and then referral out. Would they also be amenable, or are they going to be working with the existing system that exists right now, let's say for the navigators, for the referrals, and with the different enterprise members? They all may have the same type of system in doing the patient navigation, et cetera, but with the data, our data now all in one place, would they be able to look to see how they can create an efficiency in the process?
So that is our job. So I think what their job is to help us implement the platform in the ways in which Melanie just spoke of, and to create a smooth system on both ends. It is our job to then take that data and the reality of the system and create efficiencies, and so that's what you pay us for.
Okay.
Sherry?
I'm going to call the question.
All right. I need a second.
Second? And then we need a vote.
Do I have a second?
Yes.
Okay. We have a motion and a second to call the question. All in favor?
Aye.
Aye. Any opposed? Any abstaining? Okay. The motion is on the floor. All in favor? Aye. All opposed? Any abstaining? Motion carries.
Thank you, members.
Thank you.
Thank you very much. Thank you.
Just two.
Okay. I'd like to take a 5-minute break. And there's food next door in case you want to get some. And we'll be back in 5 minutes, which is about 7:40. Thank you. I'd like to lay out agenda item number 4, receive and discuss a report on Central Health's historically underutilized businesses. And I have Mary Quintero and Jeff Knodel.
Thank you. So I want to kick it off real quick, and then I'll turn it over to Mary for the presentation. This is annual historically underutilized business report. I want to pause for just a second and say, excuse me, I'm not getting any audio from that mic.
I think he's on.
There we go. Okay.
He's on now.
Sorry, that was me. So let me pause for just a second. Mary, even though it seems like she's been here for a long time, is still relatively new, and she's really stepped in, done a really great job in our purchasing area, and really helped solidify our processes. So this is our annual report. And then the last thing I'll say before I turn it over to Mary is a lot of governmental entities, as it relates to historically underutilized businesses and their solicitation or purchasing processes, use a disparity study to actually establish goals related to types of solicitations. Central Health does not have a disparity study and instead uses what's called a good faith effort, which means we do everything that we can to encourage participation in our solicitation processes, but we do not have established goals. And I know that some of the government entities around here have done disparity studies, but I just wanted to point that out up front. So with that, I will turn it over to Mary for the presentation.
Hi, good afternoon. So I wanted to talk, like Jeff said, we don't have a regular hub program. I want to call it a hub initiative, and Central Health adopted that in regards or in response to the board of managers that approved and suggested that. So what is a good faith effort? That is our outreach to all the vendors and proposers, bidders, to encourage them to solicit minority business or companies that are under the designation of a hub. In our proposals, we always encourage that the vendors and the contractors get subcontractors, at least that they are hubs. And we also have some language on the solicitations asking and saying what Central Health does with that, and that we request that they do the best they can to solicit minorities. On the definition of hub, to be eligible to be a hub, a company has to be small enough, has to be 51% or more women-owned or Asian Pacific American, Hispanic American company in order to qualify for that. So a hub has to be recognized by a governmental program, and that can be the city of Austin, the county, or the state. Also the Texas Unified Certification Program. Now, do we, Central Health, verify the status? Yes, we do. We request from proposers and bidders to send us a copy of the certificate, their hub certificate, when they are claiming that they are. And also we go then into the CMBL website to double check that the minorities or the hubs are indeed in there and that they are active. In addition to that, we also go to the bar, federal and state bar, to make sure that these companies are not prohibited from doing business with government entities. Section 34 of the Procurement Administrative Code identifies the minimum size of a company to qualify as a hub. Once a company goes over that, then they do what they call graduate. And so that company graduates and is no longer eligible for hub status. That means that they have reached a competitive level, and therefore they don't need to have a particular consideration. on eligible and illegible expenses. The expenses that are eligible is heavy construction, building construction, some special trade that, for example, plumbing, roofing, electrical. It also includes commodities, and the commodities can be all the way from office supplies to IT equipment, for example, medical supplies and other consumables. The ineligible category is pretty self-explanatory, is wages, travel, salaries, and so on. Our hub eligible expenditures this year include operating and also capital expenses, and we were able to award 11.83% of our total expenditures to hub businesses. The total award, as I said, was 11.83, and here is a more visual slide. So as you can see, it has gone down this year, fiscal year 2017. The expenses that were awarded to minorities have gone down a little bit, and mainly the reason is because we have not had a lot of construction, which is the work that lends more itself to contract minorities.
So can I pause for just a second? So
Yes.
to go back to this slide, so the 11.83% is a combination of adding both the operating expenses and the capital expenses. So you see two rates, one an operating expense and one a capital rate, a capital participation rate, and then the 11.83% is a weighted, kind of a weighted participation percentage. So just wanted to clarify, there's a lot of numbers on this slide, what they're made up of.
And in here is, like I said, this is where you can see it going down a little bit because of lack of construction, not a lot of expenditures on that. And in here, there is a breakdown of awards by minority type and different percentage awarded to different governmental entities. So we have the state of Texas expenditure at 11.97%. The Travis County was at 7.2%, and the city of Austin is at 10.33%. So in general, I think that Central Health is doing very, very well at 11.83.
And I'd also add, just, again, this is a really busy slide, but you see some of the classification breakdown for fiscal year 17 as it relates to categories. You see African American, Hispanic, and women-owned breakdown. And then we also are showing you on the right-hand side a 3-year kind of running analysis of what the participation amounts have been over the last 3 years, so fiscal year 15, 16, and 17.
The colors are pretty, though. I know it is busy too, but
We wait till after the presentation, ask questions.
Yes, please.
okay. So now to tell you about our outreach efforts, we really do and use a lot of electronic media to notify sellers and vendors of the opportunities that we have and for them to participate. We use BidSync, which is a company, it's a website that houses thousands of vendors of companies, all sizes, all different commodities, different services, and vendors register in there. They register for free to get notifications of any opportunities that are coming up in terms of solicitations. So there is a big list that is put out by NIGP, which is a national program, procurement program, and it has different codes. It has, it has a few hundred. And those codes, for example, 1, 2, 3, 4 will have commodities, 3, 4, 5, 6 will have construction and so on. And then it has subcategories under that. So when a vendor registers, they go select the NIGP code that goes with their company, with their area of expertise. And as soon as we have a solicitation, the system directly emails and says, okay, well, there is an opportunity here, really in the field that you have registered. The ASBD is a government website that we also use to advertise solicitations. The ASBD is linked to our website, so the moment that we post a solicitation in that platform, it directs, puts a link on our website as well. So that is another way to promote also the opportunities. We also locate hub vendors on CMBL, which is the Centralized Master Bidders List, and it's another state website that has hub directories. And there are, I don't know, hundreds and hundreds of companies that are minorities. You can search per commodity and just select the minorities, the hub vendors, and then you can target them directly to basically tell them here is an opportunity, and you're welcome to respond. We also keep information, contact information. We have vendors that contact us directly. Do you have anything on this area or the other area? And if we don't at that moment, we keep the contact information. When an opportunity comes around in that field, then we go ahead and contact them directly from the purchasing email directly to these companies that have asked us or have contacted us for about our solicitations. We encourage all vendors also to register with BidSync so they can get notifications, and that is also in our solicitation papers that we have we list in there all the different websites, and we encourage them to register to get notices. In addition, we also advertise in newspapers 2 weeks as required by law, and we think that is a pretty good outreach effort, advertising in all those websites, and we're very happy of what the solution or the response that we have had, and the 11.83% is really, I think, is really, really good for us. It shows that we are really doing some outreach and we're being successful at it. Thank you.
Thank you very much. Appreciate your presentation. This is a discussion item only, so I would like to just entertain questions for the presenters, and I will start over with Shannon.
Just 2 quick questions. The first one, under the HUB, the Hub Comparison Report, this profile here, are these weighted equally with the state, Travis County, and the city? Well, you mentioned this 11.83 is weighted from capital and operational. Is that also weighted in these other areas as well?
It's a percentage of eligible expenses and participation in those eligible categories.
Okay, so there.
Yes, so I think the answer is yes.
And then the second, last question is, you advertise in traditional Spanish language media outlets, including The Statesman and La Prensa. Do you do any African-American newspapers?
I don't believe so. I am not certain.
The COA, there's a whole bunch of us.
I think we'd be really interested in getting some feedback from you and other members as to what some opportunities are. So any opportunities, we'd be more than happy to follow up on that.
Okay.
On those.
Thank you very much. Julie? No questions? Sharon?
No questions.
Sharon? You good? Cynthia?
With respect to the growing population that we have in the Asian American community, which is, I think, the second fastest growing population here in Travis County. So it was interesting to note that we didn't contract with anybody in 17 this past year. Is there a reason for that?
I don't know that there's a reason for it, but it's something that we're cognizant of, and we will continue to look at opportunities.
We really do need to look at fixing that. And the same thing with what Shannon referred to, and that was the advertising in the various language or media outlets. You know, they have community and cultural little newspapers, newsletters that we could clearly advertise in. You know, out of the Asian American Center, you know, out of all the other communities and ethnicities that are here. This is a diverse population that we serve, and it's changing, it's diversifying even as we speak. And so I think that we really need to make a genuine effort to make sure that we touch them all, and make sure that we have representation, or that we have we're spreading the wealth around. We're spending money in each of the communities, because those are where our populations are growing, and that's who we serve. So that's something I'd like for you to consider. And, you know, there are other things other than La Prensa and the American Statesman. You know, maybe even something online, you know, which might be able to be had for very little money, if any. Some things that we can do that we may not necessarily have to spend money on. So it would be a good idea to investigate,
Yes.
to see whether or not there are other options.
And thank you for bringing it up. I mean, I think we're going to challenge ourselves this upcoming year to really reach out and try to intel using some of the media, those options. So I know we've talked about doing that, and I think we really need to buckle down this year, and especially if we have some additional capital opportunities coming up.
And I will again.
It's imperative that we do.
So I thank you all for the work that you're doing. But I, again, am going to reiterate my concern that Central Health did not participate in the disparity study when I was here personally advertising or, you know, pushing you all to participate, when the city did and AISD did. But if ever there's an opportunity to spend a little bit of money to see if there's a way to do a modified version, I'd like for us to consider it. That's all.
That's a great point. Appreciate it. Autumn? No questions. Thank you very much. Really appreciate it. Item number 5, discuss and take appropriate action on the homestead exemption from Central Health for Travis County residents over 65 or disabled. We're actually going to postpone that item until our next budget and finance meeting. No, we have time, and I'll let Jeff sort of explain that, but we have time to sort of discuss this issue. It probably will be a fairly long discussion for us, and I encourage you to look at the information that's contained in your packet and get your questions and sort of understand where you, as a board member, stands on this particular issue, so that you can articulate that when we do have our discussion and expedite that. I think many people can look at this issue from a number of different perspectives. And so as we do, it's fine, we need to hear everybody's opinion, but eventually we're going to have to make a decision. And so
I was actually ready to make a motion.
well, not right now.
Not today. I guess not today.
Not today. So, Shannon?
As a citizen over 65 in Travis County. It'd be a conflict of interest.
Not a legal conflict. If you ethically feel you should abstain.
Is there a duality?
Just barely over though.
Oh,
I'm getting close.
I'm not there yet.
Okay, so with that said, Jeff, did you want to?
Can I add one, just real quickly, and thank you.
Sure.
So the Travis County Commissioners Court ultimately approves the exemption amounts. So when we come back, and again, we'll come back next month, so we're not in a tremendous hurry. Travis County did present their item this last meeting. So we had some information. I wanted to start teeing it up. But the Commissioners Court will ultimately have the decision. We need to have a decision made by April would be a really good target. So we have a couple of opportunities, even at budget finance, the next meeting and the subsequent board meeting. But I wanted to start presenting some information. I have to take a guess at what I think the number might be, so if there are other options, please let me know. There it is. Thank you.
Thank you.
With respect to this item and the future discussion, may I just ask if you will be able to provide us some information as to the impact on the tax revenues for the year in increasing the amount and cutting out that amount of revenues from our property taxes?
Yes,
Is that going to
so,
be something that's going to be given to us?
well, if you'll see in the memo, again, I took a guess. The city and the county now have the same exemption amounts, the optional exemptions related to over 65 and disabled. So I took a guess using that number. You'll see an estimate of the property tax impact, and then you'll see the impact to the individual taxpayer that would qualify for the full amount, the delta of the increase. So again, if there's another number you'd like me to look at, I'll be more than happy to look at it.
And I appreciate this, but what I will also be interested in is geographic, where those populations reside.
Okay.
Okay, so it could be that they're not downtown.
Right.
But they are in the Eastern Crescent.
Sure.
You know, or something like that, so
Okay.
that would be interesting.
Okay. I'll work on that.
Thank you. Okay. I'd like to now lay out item number 6 and 7, since Jeff is going to do both. Item number 6 is to receive and discuss a report on the January 2018 financial statements for the Community Collaborative, and item number 7 is to receive and discuss a report of the February 2018 financial statements for Central Health. Jeff?
Thank you. So we'll start with the Community Care Collaborative, and I'll go rather quick on both of these items. So for the CCC, the Community Care Collaborative balance sheet, sources and uses, and then healthcare delivery summary. 4 months into our fiscal year, as of January, our comparative balance sheet as of January 31st, you see total assets of almost $81 million, made up primarily of cash and cash equivalents, accounts payable and accrued liabilities of 18.2, total liabilities of $21.6 million, net assets, which are the difference between assets less liabilities, of $59.4 million. Sources and uses, as it relates to activity this period, you see 2 columns, our approved budget, and then our year-to-date actual, and again, this is through January 31st. A couple of large events happened in January. First, we got paid for the Deseret project, so again, the CCC reports on accomplishments, reports that to HHSC. There's a somewhat lengthy approval process. There was an IGT made for that in Central Health in December, and then the CCC was paid for their accomplishments in January. That was $56.5 million. There was a seat and member payment of $10 million. And then, excuse me, on our operations contingency forward, we completed our fiscal year 17 audit. So we have our roll forward from the previous year. That's a source of funds, and that's at $13 million. On our uses, healthcare delivery is at $24.8 million. And then again, our Deseret costs are a little bit under $500,000. Again, we'll expect to see Deseret project costs remain fairly low as we progress into the new year. And then on top of that, the state or the program, as we roll into the new, I'll call it phase 2, they have changed the, I don't want to say fiscal period because it gets confusing. The fiscal period, which we called a demonstration year, has now changed to a calendar year. So we'll see a transition on that also. So, sources over uses is $54.3 million. On our healthcare delivery cost, let me first point out, there's an error in the packet, and we've made a correction on the year-to-date actual, the total. In the packet, it's $22.7 million, and you see up on the slide, the correct total is $24.7 million. So you see overall a budget of $103 million. We're at $24.7 million. Aggregately, we're at 24% of our aggregate budget. And then you see a majority of that is related around primary care, which is at 29% of our budget. So as it relates to our primary care budget, again, we're at 29%. The majority of that budget.
That was for our last item.
Oh, okay.
We're a little
So I could even talk faster if I need to.
Oh, we're time.
So, sorry. All right. So, community care is our majority of our primary care, spend in primary care. They're at 28%. And then you see a itemized listing of our other providers in that area. And then as it relates to healthcare delivery operations, you see overall we have a $12.9 million budget. We're at 18% of that budget, and you see the itemized departments within healthcare delivery operations. That concludes the CCC presentation. I'll pause for any questions.
Any questions? Madam?
Yes, thank you, Jeff. I have a quick question. As you mentioned, you're 24% in healthcare delivery up to date. Is that typical to where we are from the past years? Have you noticed more services being rendered? Are we having additional patients? Just can you give
I think the perspective I would have is we've seen trends of increasing access. As we get into more value-based contracts, there are more, there's some risk. For example, community care, they have some metrics, performance metrics that they would hope to achieve. And if they achieve those, they would be incentivized with a payment. Most of that occurs at the end of the year. So you may be seeing, you may have more access, but it gets into a kind of a performance mode where you're paying some of the cash payments or more on the back end of, can I call it the cycle? It's not just a straight fee for service where you provide services for a month and you're paid for those services. We do fee for service. I'm just saying that some of that spend is more towards the back end. So I think the quick answer is yes, we are seeing more access. We've changed some of the payment methodologies up to where there are more capabilities to see appropriate level providers. RN visits, nutritionists are examples of some of those that, you know, we've changed some of the payment models up to have appropriate accounters to have more access. That's a long-winded answer to say, yes, I think this is appropriate to the patterns that we've seen in the past. We typically start out a little slower, and as the year goes on, we typically we pick up some momentum in that.
Thank you.
Cynthia?
On slide number 5, we're about what, halfway through our fiscal year?
Well, these are statements through January, which would be 4 months. So it would be 4 months of.
Right, we changed to a calendar year, is that what happened?
No, it's
So
through January expenditures, October, November.
Our fiscal year.
October, November, December, January, February. Oh, this is through January. Okay. Okay, so it doesn't include February. But even so.
And we're planning to get, I know we've been tremendously short-staffed. We will get caught up.
The reason I'm asking is because I'm looking at specialty care, and it says we've only used 13% of our budget for specialty care, and we have huge problems. We've got wait times, we've got people that still haven't been seen in years, and they need to be seen. So we've only used 13% of our budget for specialty care. For post-acute care, we've only used 6% of our budget for post-acute care, of that money that's been allocated. And yet we've used, for medical management, we've used 41%. What are the reasons?
Can I just throw, I would like to take a mulligan on this, if that's the case. I don't know that these are appropriately classified. We are going to have to come back, and that's one of the reasons you don't see specialty care. We ended up, for this particular monthly statement, we're going to have to come back and really look at that. One of the difficulties we've had is the third-party administrator that we've had has not been processing claims near as efficiently and as we had hoped.
When did we enter into contract with that third
It
party?
was-
I remember it was not that long ago.
Yeah, it was last year, I want to say late last year. And so we had a implementation period, and we are having difficulty processing payments. And so that makes it really, really difficult. And I probably should have started off saying something like that. It makes it difficult to both estimate what's in the queue and then appropriately classify those. So we have made a lot of progress this month, and we hope to bring both February and March statements in the April Budget Finance Committee, and we hope that should more appropriately report where we're at. So I should have started out with that.
I appreciate that. I just want to know whether or not that third-party administrator is going to be able to perform, or whether or not we're going to have to look at something else. Because I really would like for us to try and stay on top of our specialty care and post-acute care.
Well, it's imperative that we have a third
Especially as
party.
we're looking at 41% medical
It's
management.
imperative that we have a third-party administrator that can perform. That's been the basis of how we're going to obtain claims information.
That's right.
We're taking what I would consider all the appropriate actions that we can. We may have some limited options, but we're looking at those options very carefully. And, these are really painful transitions, so we want to make a good decision for our next step. But I would say right now, we're not satisfied with where we're at.
Thank you.
Yes, so to tack on to Jeff's answer, some of those percentages, I don't know that you could take it on a pro rata and say, okay, we're a third of the way through the year, should we have expended a third of the funds?
When I see these things, what I would like to do at some point in time, and I think we talked about this last year, is we can see where we were, last year, and compare it to where we are now, so that we can see whether there's a difference.
There needs to be a year-to-date comparison.
We're planning on.
I thought we had spoken about that last year.
We had. We were supposed to transition to that, and we just.
That's right.
Had some turnover that has prohibited us from making the presentation in a format that we would like to get to.
Okay.
So believe me, we're working on it.
Thank you, Jeff. I appreciate it.
So my apologies.
Thank you. Sherry?
Only question I had, I'm looking on the next slide of primary care, and the volunteer clinic is at 59%. I'm delighted that they are stepping up. Are they going to, do we think they're going to run through their funding before the end of the fiscal year?
I think let us get through March. And
Okay.
we'll have a lot better
Same answer. I understand completely. We'll just wait and see.
Yes.
No question.
Shannon? Okay, thanks, Jeff. Let's go on to the.
Okay. So Central Health, and I know this is a little confusing, but Central Health is statements as of February. And a couple of the highlights, we did send intergovernmental transfers of $24.4 million related to uncompensated care in February. And then remember our property tax cycle, property tax, the majority of your collections come in December for people who are paying for tax purposes, let's say, but technically taxes aren't due until January 31st. So this would be the second month where we would start seeing the full amount of the tax payment, plus, there's typically a lag because of if you're not taking tax credit, you're typically waiting to around the last day of the month. So with that said, looking at our balance sheet, and again, this is a comparative balance sheet, fiscal year 18 and 17, our total assets are $158.3 million, and the majority of that are short-term investments. Non-current assets of $78.6 million, and then capital assets of $117.8 million, for total assets of $354.6 million. On the liability side, our current liabilities are $12.5 million. And then we made a debt service payment in February. So you see a reduction in our long-term debt from $10.4 million in fiscal year 17 to $9.4 million. So we made a principal payment in February related to that debt. Total net assets of $332.5 million, and then liabilities and net assets of $354.6 million. Our sources and uses on the next page, again reflective of the property tax collections. We've collected fiscal year to date $178.9 million. We're at 98.4% of our budget. Lease revenue, you see we're at $4.4 million. And then the only other thing that I'll point out is our contingency reserve. Again, we completed our fiscal year 17 audit, so our contingency reserve amount that rolls forward from the previous year is $51.5 million. Let me pause there for a second. There's historically we had some timing issues with IGT. We got caught up in fiscal year 16 and 17. We had a slight timing difference in as it relates to fiscal year 17. So we had a IGT, intergovernmental transfer, that was done in fiscal year 18 that was for state fiscal year 17. So of the $51.5 million of contingency reserve you see, $4.2 million is what we call allocated. Remember, those are the timing differences. So $4.2 million is related to allocated contingency reserve, and then 47.4 is related to what's called unallocated. So we had a slight timing difference. Again, the state dictates the schedule of the IGT. I believe the IGT, if I remember right, was done in October, I believe. So anyway, that's a breakdown of the contingency reserve. Administration year to date is $2.9 million. We recognize our tax collection expenses as we collect property taxes. So we've collected the majority of property taxes, and so we've amortized that over those collection rates. We're at almost 92%, so that looks a little odd, not halfway through the year, but you're at 92% of your budget. But that's the way that works. Again, you've collected the majority of your property taxes. Sources over uses fiscal year to date is at $127.5 million. And remember, this is the high point of our collection period as it relates to property taxes, so you would expect to see that number be fairly high. Healthcare delivery, aggregately, intergovernmental transfers are the largest part of our budget. fiscal year to date is at 92.7. For the month, again, we transferred $24.4 million. Our provider costs were at $2.2 million. Our service expansion funds are budgeted at $2 million. And just as a reminder, we have allocated $200,000 as it relates to the Lone Star Jonestown expansion. You just don't see it on here yet because the funds have not actually been spent. But the net balance of our service expansion fund would be $1.8 million. Operating cost of $1.6 million, and then other costs which consist of the campus redevelopment, the ACA enrollment, and debt service of $1.5 million. Our total healthcare delivery expense for the month was $25.3 million. Again, $24.4 million of that was IGT. Fiscal year to date was $103.5 million. And then the last slide shows a recap of where we're at from a little bit more detailed perspective on our supplemental payments, our intergovernmental transfer payments. And so you see this month in February, we did a IGT of $24.4 million. And you see the difference, the private and the public, you see the breakdown of that. And then you see by program our fiscal year to date and then our budget status. That concludes our presentation. Happy to answer any questions.
Thank you, Jeff. Any questions?
We're going to wait till the next one.
Okay, all right.
Yeah, thank you for your patience on that. We're
Get it.
Thank you.
And Shannon?
No questions.
All right, great. I'd like to, thank you, Jeff, I appreciate it. I'd like to lay out item number 1, approve the minutes for the following meeting of the Central Health Board of Managers Budget and Finance Committee, February 21st, 2018. Can I have a motion? Autumn?
I move that the committee approve the minutes from the following meeting of the Central Health Board of Managers Budget and Finance Committee, February 21st, 2018.
Thank you.
Second.
I have a motion and a second. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion is passed. Thank you, members. And I would like to take up item number 11. The next Central Health Board of Managers Budget and Finance Committee meeting is on Wednesday, April 18th, 2018 at 5:30 p.m. Central Health Administrative Offices, 111 East Cesar Chavez Street, Austin, Texas, 78702.
Move adjournment.
Move adjournment. Second. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned.